as it gives a view of quality across England, and it gives what we hope is a truthful view, an important view to help policymakers and those providing services understand both what's working well and what services require improvement. In a moment, you'll hear from Ian Trenholm, our Chief Executive. Let me just run through the rules of the Q&A and also introduce the rest of the panel. So alongside Ian, you've got Kate. Kate is our Chief Inspector of Adult Social Care and our Inspector of Integrated Care as well. And you've also got Sean, who's our Chief Inspector of Hospitals and Primary Care. When we get to the end of the presentation, there'll be opportunity for questions. Please wait because we're live streaming today as well, please wait for the microphone to show up so you can have your question not heard just heard in the room, but heard at home as well. Please state if you represent an organisation, just state the organisation as well, if that's all right. And then we'll go to the panel for questions, and we'll keep that going for as long as that's useful for you. Okay? So without any further ado, over to you, Ian, to talk through this year's findings.
Thank you very much, everybody, and good morning. And an enormous thank you for coming. An enormous thank you for the work that you all do. You're here today because you're interested in the work that we do. We know that what you do is you amplify some of the messages from the report, and we know that we work with each and every one of you during the course of the year, and it adds enormous value to the work we do, and more importantly, to the people that we all serve. So, before I started speaking, I just wanted to say thank you to each and every one of you for coming and the work that you do during the year. Oops. Don't touch anything. Okay. So my name's Ian Trenholm. I'm the Chief Executive. And before I get into the meat of this year's State of Care report, I wanted just to remind everybody what it is we do at the Care Quality Commission. We're the independent regulator for England for health and social care, and we make sure that we can give the public and Parliament the assurance that care services are decent, they're of a good standard, and we use the inspection work we do to encourage services to improve. And each year we produce a report for Parliament, our State of Care report, and the aim there is to bring together all of the messages from the 8,000 or so inspections we do each year, and to try and look for where the insights are. The way that we work is we register and then rate about 40,000 locations, and they range in size from a multi-billion-pound trauma hospital through to an owner-operator domiciliary care service. That includes ambulances, general practice, hospices, and so on. And we ask 5 key questions in our work that range from, is the service safe, through to, is the service well led? So when we bring all of that together in terms of our annual report, our headline message this year is that the health and care system is gridlocked. The system is gridlocked and unable to operate effectively. And what that means is that people are stuck. People are stuck at home because they can't get an ambulance. They're stuck at home because that ambulance that they should have got is stuck outside a hospital with someone in the back of it. People are stuck in the back of the ambulance. And people are stuck in hospital, unable to leave because they can't get good quality social care in their area. Why is this happening? I think one of the main reasons is around workforce. There are 132,000 vacancies in the NHS at the moment. That's nearly 10% of the workforce in the NHS are vacant. That's the highest in the last 5 years. That vacancy rate applies to all regions, but it's particularly acute in mental health services and particularly in London. In London, for example, 16% of jobs are vacant in mental health services in London. And that has got to be reflected in real challenges in delivering a decent service on a day-to-day basis. There are fewer midwives. The numbers fell between April 2021 and April 2022, the largest annual decrease since records began in 2009. And there's been a 10% reduction in the ratio of fully qualified GPs per 100,000 patients in the last 5 years. And whilst that sounds like a complicated statistic, it is a reflection of the fact that it is difficult to get hold of a GP. But despite that, GP services have endeavoured to deliver more contacts with patients in a range of different ways this year than ever before. But that has its toll. It has a personal toll on individual GPs, with 42% of members of the RCGP saying they're likely to quit in the next 5 years. And that has got to ask questions about the long-term sustainability of the way in which we're delivering general practice. And when we look at social care, we have a similar story. 99% of NHS leaders warn of an adult social care workforce crisis. And this is really one of the first times that the NHS leaders are demonstrating just how closely they're working with adult social care leaders. And they're seeing at first hand that real workforce challenge that exists in adult social care, with 165,000 vacancies in adult social care alone. And the way that adult social care operators are managing that is simply closing their doors to new residents. What we're seeing is that adult social care services are often operating at about 80% of capacity. And yet we know that up the road, the acute hospital is full to the brim and can't discharge people. And there are around 500,000 people who are waiting for some sort of adult social care or some sort of payment or assessment to happen. So there's a very real human cost to all of this. But you add the vacancy numbers together and it's 300,000 people. That's the size of the population of Newcastle. That is an enormous recruitment challenge, and that's what's necessary to simply get back to fully staffed NHS and a fully staffed social care group. What does this mean for people on the ground? It means you can't get a GP's appointment when you want one. You can't get a dentist's appointment when you want one. People say that when they go to A&E, that they're waiting very, very long periods of time. Even when they're trying to do things differently by picking the phone up and dialing 111, there's very long call wait times, very high call abandon rates. Or people, when they are in an ambulance, are waiting a long period of time outside the hospital. And they also know they can't leave the hospital as they can't get the right support at home that they really want to, even when they know that they want to go home. That's the human cost to all of this, but there's an economic cost to this as well. We all know people who are waiting for an operation somewhere, maybe having to have time off work as a consequence, or they're having to take time off work in order to look after a loved one. So this is not just a human challenge, it's an economic challenge as well. Alongside this, we've identified two other areas of concern that we've talked about in previous years. The first is maternity services, and the second is services for people with a learning disability and autistic people. And in maternity services, 2 out of 5 services are still not good enough. That either requires improvement or inadequate using our ratings. So the headline is that maternity services are still not good enough, but that masks some significant inequalities beneath that. One of the most stark, though, is that black women are 4 times as likely to suffer complications in childbirth than white women. And the figure for Asian women is twice as likely. That cannot be acceptable. That cannot be acceptable. And what's particularly staggering is I said this yesterday to a room full of press people, and almost none of them have repeated that statistic. If we move on to talk about learning disability and autism services, I think we still think care is not good enough. We talked about this 2 years ago. We wrote a report on levels of restraint and seclusion. It talked about people being looked after hundreds of miles away from where they live, breaking the link between their friends and their family and the community in which they were brought up. And people spending many, many years in acute services for learning disabilities and autistic people, way longer than they needed to. We made 17 recommendations in that report. Only 4 of them have been partially met and 13 have not been met. And there are still too many people in hospital. That model of care is still the wrong model of care. There are still too many people in hospital. Despite all of this, though, I think we do see on a daily basis some fantastic efforts by some brilliant people that work in health and social care. The people that work in health and social care are trying to deliver great care, but are struggling to do so in a system which is gridlocked. And the time is now. The time is always now. But the challenges that people that are faced really, in large part, are driven by historical underinvestment. And we think the focus must now be on long-term planning and sustainable investment. Local leaders need to join up the pockets of innovation. As we go about the country, we see lots of good ideas, lots of points of light. The question is, how can those points of light be joined up? How can those pieces of innovation be joined up in a way and then scaled? And it's important in amongst all of this to think about data. Data is never very exciting, but the public would expect that as you move from service to service, your records would simply flow with you. They would expect that local leaders have a good understanding of the population. They would expect local leaders to understand how things break down by social groupings, by demography, by ethnicity, and so forth. But it's clear that isn't yet the case, that providers are still not collaborating well, still not sharing data in their local towns and cities. And we think a real step change is needed in terms of attracting and retaining staff. Better pay is part of the story, but so is training. And so is creating an environment that's exciting and interesting to work. How do we inspire our young people? So when they're the 18-year-olds who are leaving school over the next few months, how do they think, you know what, I'm going to build a career in health and social care. I'm going to build an exciting career, and I can see a future in it. It isn't just a job for today. Because I think we do have to recognize that health and social care as a sector is competing with hospitality, it's competing with retail and so forth, and they're all paying more money. And the gap between what's being paid in health and social care and what's being paid in the wider economy is getting wider. And as the cost of living crisis increases, people are going to make decisions about where they work. And in many cases, it isn't in health and social care. And of course, there are no quick fixes, but there are steps that national leaders can take, national action around planning, investment, and workforce to set the context for local leaders to operate, local leaders to bring things together, to create collaborative relationships at a very local level, which enables the fantastic people that work in health and social care to do the great job that they signed up to do, and ultimately to deliver the joined-up, high-quality services that everyone in this country deserves. Thank you very much.
So it's now over to you. Two of my colleagues, Mark and Hannah, are going to have microphones ready, so please put your hand up to ask questions. Before we begin the Q&A, I should say that State of Care is an important day, but it isn't just about today. The messages that we give in this report will form some of the work we do of the campaigns over the next year. So in the context of what we've talked about today, don't think about it just what we sell today. This is what we talk about in the coming year. So, hands up. How did I know that would be the case? Bren first.
Bren McInerney. I volunteer in my local community and I'm privileged and proud to work with and alongside the Care Quality Commission, and thanks for all you do. So my question, having read the report and certainly the section on the inequalities, is I'd like to see more focus on the measures and impact of it. I think what I see locally and some other parts of the country is that it's not that we're not doing things around that. We're not, I don't think, joining it. And if I were to ask the question of leaders, how do you know that you're making a positive impact on inequalities? Because it can obviously go both ways. So I would ask the Care Quality Commission in their convening role to have a much, much more focus on measures and impact of that intervention. Thank you.
Do you want to start with that one?
Thanks for the question, Bren. So you'll be aware in the Health and Care Act 2022, the Care Quality Commission will be having these new powers around assuring local authorities and integrated care systems. And I think about how excited I am about that prospect when I think about our opportunity to hold integrated care systems, to hold health and social care leaders, to encourage them to focus on issues around access and inequalities within their area. So as we make our way around integrated care systems in the next few years, I will be looking for them to show a really good understanding of their population. So Ian's point about how are local health and care leaders using the data they have about their population. And I would be looking for them to show how they are going after maybe 2 or 3 key areas around inequalities, what they're planning on doing about it, and how they will measure and know that they had an impact on it. So there is a new opportunity with integrated care systems and our role around assurance to support health and care leaders to keep a really good focus on what they're doing around inequalities within their local area, with a real emphasis on demonstrating that you've had an impact as a result of the actions you've taken.
Thanks. And I think, yes, Jim?
Good morning. Helen Molinos. I'm the Chief Executive of POWER. We represent the largest independent advocacy organisation in the country. Really welcome this report and really welcome your findings around inequality. We also see the gridlocks as well, supporting 500,000 people a year, and we proudly work with you in many places around the country. Do you think that there is an opportunity for the CQC to bring together policymakers, local leaders, charity leaders, to drive that information? You know who we all are. Is there a role for you to connect us in sort of innovation labs in the coming year?
Do you want to start?
Yeah, I'll start that. Thank you. I think there probably is. I mean, I think we've tended to take a view in the past that, we stay in our lane, as it were, in the sense of we have a role to do around registering and regulating services. But I think as we're starting to take on the new duties that Kate was describing around integrated care, I do think we need to start to think much more broadly than just a cluster. An ICS is more than a cluster of services. It's more than sum of its parts. And I think we need to be starting to be quite thoughtful about what that might look like, and how we frame some of these conversations. Because just to link Bren's point and your point, and my kind of, if I'm honest, irritation about the way that the small reference we made to inequalities in our press material just simply has gone nowhere, and that asks the question in my mind around how we frame inequalities. Is even the word inequality, does that turn people off? Do we need to think about the concept in a different way? I think there's some really important conversations to happen, and I think those conversations can only happen with the groups of people that are in this room. So I think it is something that we'd be keen to do. Thank you.
I think there's a build on that as well. There's a really powerful role that working with organisations like you, because we go out and we regulate, we deliver our regulatory activity, but you're often with people when we're not. And actually the role that we have together to understand the impact on people as they journey through different parts of the health and social care system, I think it's a very important narrative that we can bring together about people's real experience of care. So I think we'd be keen to talk about what more we can do in that space.
Welcome that very much.
Okay, great, thank you. I think the lady in front and the gentleman behind.
Thank you. I'm Fazile Hardy. I work for Disability Rights UK. First, a thank you to the Care Quality Commission for putting a mirror up to the health and care system, because I don't think you've said anything that lots and lots of other people aren't saying, but it's important that you say it because of your role as a regulator. It does strike me, though, that no one's kind of listening, certainly in government, and the government's response to this report and to many other reports is woeful. I just want to make 2 thoughts, really. Is there more the Care Quality Commission can do to help social care be treated as an equal partner? It's often kind of framed as, oh, social care doesn't work and that means people can't leave hospital very easily. And of course, I know you say in your report that 500,000 people are waiting for social care. People with disabilities who need social care to live independently, to live good lives, to get up in the morning, to have a life, we're not getting it. And I just wonder if there's more the CQC can do to actually talk more about care, not as an adjunct, just an adjunct to the NHS.
Yeah.
And I know you do that, and I know there are themed reports, but I think anything you can do to get that sense that social care is really an important part of the system and not just something about getting people out of hospital, I think would be valuable. My other thought is just, you know, going back to my first point about government listening being so woeful at the moment, I mean, even more woeful this week, obviously, whether, you know, whether the CQC could actually consider doing state of care reports for the 42 integrated care systems, which again really help them see their systems, because some of this stuff is because care and health don't work well together, or because individual bits of health don't work together. I absolutely take the point about underfunding across services and understaffing particularly. But I wonder if now we need to look to the 42 integrated care partnerships to begin to deliver in their areas while we have this kind of vacuum in central government.
Yeah. Okay, do you want to start with
Yeah,
that?
really happy to. Thank you so much for the question. So as a social care person through and through, I know the weariness of hearing social care talked about as predominantly being older people, care homes and hospitals. So I absolutely understand that people in social care are desperate to talk about adults of working age, desperate to talk about social care as a means for having a meaningful, vibrant life, rather than some of the more negative connotations that are out there. We describe things in a way that we hope will have as big an impact as possible. So we know people don't tend to know about what social care is until they come into contact with it. And we know that generally, from a public's perspective, people think about social care as having a key role in supporting people to leave hospital in a timely way. So obviously, we've used that in terms of describing the health and social care system as being gridlocked at the moment. But also, we have majored heavily on the 500,000 people who are not getting the assessments, who have eligible care needs and are not getting the packages of support at home, or being able to access a care home when they need to, and for those needing reviews of their care and support. So we will continue to talk about social care as life-enhancing and adults of working age, and the kind of spectrum of services that are in that kind of rainbow of social care. But also, when we pull together these reports, we are thinking about what will have big impact around the issues that you were mentioning, which is that need for things like long-term sustainable funding for social care. Two other bits. When we start assuring local authorities, so we will have new powers to look at how 152 local authorities are meeting their Care Act duties. So how are they assessing people in a timely way? How are they managing their markets so people have choice, etc.? That will give us a new opportunity to talk about how local authorities are doing their job around making sure that people get assessments. And then when we start doing our work around integrated care systems, we absolutely will be providing information for that local system, but for that local population as well, about what it feels like to access health and social care within Leicestershire or Buckinghamshire, for example. So there will be means for us regularly sharing what we know about integrated care systems with not only the people in the system so that they can do the improvements that are needed, but also with local populations so they have a good understanding about what they can expect from health and care within their place.
Just to build on the point about MPs, two things I'd say. One is that one of the things that's in this year's report, a piece of work we did with Skills for Care about 2 years ago now on the economic value of social care was really important. A big chunk of the value of social care is actually it brings more adults of working age back into the population, either because they're no longer caring for family members or because they themselves can work because they've got the appropriate social care to support them. And actually, that's in a tight labour market, that is an important feature of our work. The last thing I'd say is that as the current Parliament, there are 80 MPs who are elected in a constituency that has a health issue as a key feature of how they are, in a sense, how they're put into power. So local campaigns were built on not just a health but a care platform. So we will be taking state of care directly to those groups, as we do every year, so that they can understand the implications, not just nationally, but locally for them. And I think it's a combination of things that will play out. So good conversations with the Treasury about the economic value of social care, and good conversations with local MPs about the implications for them of a failure to deliver good care in their area. Next question. I think this gentleman is right. Yeah, it was almost a race between you two last time, so I want to make sure he gets his. I think we're probably next to Andrea.
Thank you very much. I'm Julian Metcalfe, an expert by experience. For those of you who are not quite sure what that is, we support the CQC in undertaking their inspections as sort of lay inspectors. Thank you very much for this very powerful presentation, and I think we are all very grateful for what the CQC does in conveying these quite difficult but powerful messages. My question is, I particularly welcome the introduction of these integrated care systems at local level, and I think that's an important aspect apart from workforce planning. My question is, and it's one of reassurance, is that the skill set for evaluating the success and impact of those new systems are somewhat different from those skills which the average inspector has, and does the CQC have the right set of skills, more management consultancy in a way, to address those issues? Thank you.
Do you want to start, Kate?
Yeah, thank you. Thanks for the question, and thank you for what you do. Our experts by experience are absolutely critical to the work that we do out there when we're regulating. So thank you first. Yes, so as we build up to these powers going live, we will be looking at what capabilities, what skills we need within the organisation to deliver our work in a way that's credible and that systems recognise and respond to positively. We don't know exactly what it's going to look like yet, but I think back to the local system reviews that we did in CQC back in 2018-19, where there was a combination of inspectors and inspection managers alongside people that are out there in the field. So it could be a current serving director of social services or a current chief nurse of an acute hospital going out with our inspectors to a place. So they bring that kind of live, up-to-date experience as well. So the next 6 months or so, we will get clearer on what that will look like. But I would imagine it will be a combination of inspectors, people who use services, families, and potentially people currently serving out there in health and social care to kind of form mini teams when we go out. But if you can not hold me to it, because we haven't quite finalised that yet. But we recognise we haven't got all the skills we need internally at the moment to do this new work.
Great, thank you. There's one at the front and one at the back. So we've got the lady with the blonde hair at the back and Andrew at the front. Go either way. We'll get to everybody. I'm just trying to do it in order of how fast the hands are going. Yes, you first.
Thank you very much. Andrea Sutcliffe, the Chief Executive, nearly had my old job title there. Chief Executive of the Nursing and Midwifery Council and previously of this parish. Thank you very much, everybody, for the report and the work that's gone into it, which I know from bitter experience how much that is. But I really feel your frustration, Ian, in terms of some of the messages not landing. And I reflect upon that in the week that we've just had the East Kent review into maternity services, which highlights appalling tragedies there, which are reflected in your overarching figures. And hard on the heels of the birth rights report, the 5 times more reports earlier this year highlighting those inequalities that you identified. So we know there are problems in maternity services, and as Bill Kirkup said this week, just recommending that things have got to get better isn't actually helping. And from a nursing perspective, particularly on social care, this comes after the Skills for Care report last week, identifying really devastating figures, frankly, in terms of the numbers of nursing vacancies, turnover, and the impact that we know that has on people living in very vulnerable circumstances in both the working age population as well as older people. So I guess my question is, what can we all do? Because We have been here before. We've raised these concerns before. I've raised these concerns in this role with the kind of vacancies, nurses and midwives, the impact of stressful working conditions, the inequalities that people have faced, the impact that that has on poor care. And so is the CQC. But what can we do together to actually this time really make a difference?
Do you want to start? Or do you?
Yeah, I can start that, and then maybe Sean can come in on that as well. I think there's something about having the difficult conversations, because I know you, Andrea, your colleagues, and a number of other colleagues, we collaborate together on national groups and all of this sort of stuff, and I think that still needs to continue to happen. But I think sometimes we maybe all shy away from having the really tough conversations. Why is it that that doctors in maternity can't have a good relationship with midwives? Why in some units is that relationship just break down to the point of being dysfunctional? Why is it that we saw in an inspection earlier this year that we had senior leaders on the unit shouting at our inspectors because they were all dressed in scrubs, so our inspectors weren't obvious, so people were shouting at them. People were shouting at black women for not being able to speak English properly. Those things are still going on in 2022, and we take prosecutory action and we take bits and pieces. But actually, we need to have this grown-up conversation that just says, look, actually, how do we get to the point of calling these things out in a really unambiguous way? Those of you who are veterans of these events will know that we've been a bit more punchy this year. Normally we craft our messages and they're beautifully smooth, and we try not to aggravate people. But we've been a bit more direct this year, and I think that's a good thing. And I think we need to call these things out in a very clear and unambiguous way. I don't think there's a silver bullet, but certainly that tone of voice that we all adopt, where we just sort of say enough is enough, that's not acceptable. Whereas we've kind of slightly knocked the rough edges off maybe in the past, and we need to stop doing that. Would be my starting. But Sean.
Yes, thank you. Well, I think part of the answer for us is around better ways of detecting this sort of thing earlier, getting more reliable indicators. So that's earlier detection, and I think the Kirkut report talks about that. I think that's very welcome, and we're always trying to understand what are the key indicators for when organisations and when services within organisations are starting to deteriorate. But it's not just about early detection. Obviously, the better avenue, the more productive avenue is around prevention, and how do we prevent this from occurring? And our role can be, I think, we may have a good role to play in the highlighting good practice and understanding. It's not just highlighting the good practice; it's understanding how that good practice came to be in that place at that time, and learning from that. So it's as important to learn from the places that are getting it right, because there are places that are doing well, to learn from them and to share that learning and to make that to understand it and then share it. I think so. There's a number of things we can do.
Just to finish up, I think ultimately this is always about trust and transparency. We brought together a group of midwives to talk to us about their experience of delivering care, and that was really eye-opening for us in terms of what it really meant for them to work at the front line of care and their relationship with other parties. And I think it taught us something about what we need to look for when we go into services. So building that trust so people can be open with us about their experience is really important. And then transparency, both in the good and the bad, what's working well and why, and what isn't working well, and being quick to both spot it, action it and deal with it as a group. I think your point about what can we do together is really important, because it may be that we take collective action with collective insight to drive the right behaviour and the right performance in organisations. Next question. The lady at the back was almost the same time as Andrew, so I need to go her next.
Thank you. I'm Helen Wildbor. I'm from the Relatives and Residents Association. We work with older people who need care. A slightly more challenging point from me, if that's okay. It builds on the last question around the news yesterday about people being let down by maternity services in Kent. The week before that, we had the appalling footage of Anne King being abused in a care home in Surrey. The week before that, there was headlines around a care home in Cambridgeshire that was finally being closed 3 years after 4 bereaved families raised concerns. And the week before that, it was the undercover footage of a mental health trust in Greater Manchester and abuse of patients. And the common denominator in all of this is the regulator. And it suggests a pattern, and I'm afraid it's a pattern that we hear coming through our helpline. Too many people call us and tell us that they just simply cannot rely on the Care Quality Commission to be there and to be their voice and to act when they raise concerns. And it's been a terrible year, as we know, and it would be too easy to dismiss these as just, it's been we're still in a pandemic, but some of those examples actually predate the pandemic, particularly the care home in Cambridgeshire. So my point really is, people who call us are desperate, and they are desperate for their regulator to step up and be their voice, and there's nothing that can compare to crossing the threshold and being there to, as you say, to spot things earlier. And they're relying on you as the organisation that has the power to do that, so that they don't have to fight these battles on their own.
Ian, do you want to just start?
Well, I'll kick that off. I mean, I think it's worth saying, today I've got we have about 40 inspectors out doing inspections. We do about 8,500 inspections a year. We took about just under 800 prosecutions last year. I think we are out and about and we are crossing thresholds. But I do think it is worth just being really clear about the limitations of our powers. We don't have the power to take up individual complaints and pursue them in the way that I know a lot of people would like us to. That's not how we were set up. But what we do say is we've seen a 50% year-on-year increase in people talking to us about the care that they receive, and a similar increase in the number of people who work in services talking to us. And that's driving our inspection. Most of our inspection activity is risk-based, and so we're now getting out and looking at the higher risk services and making sure that that's where we focus our work. So, and I completely accept there are places and times when things go wrong, and when there is an individual who does bad things, frankly, and we and other partners, whether that's the police, whether that's local safeguarding teams and so forth, act accordingly to deal with them. And I'm never satisfied that we get it right all the time. We're constantly looking for different ways to tweak what we do in order to make sure we can be better at what we do. But I think my appeal would be that people need to tell us what's going on good and early, and we can make sure that we pick that up and pursue it. But I don't think we can set an expectation that we will investigate a complaint, each and every complaint. That's not what we have the legal power to do. So I know sometimes people really struggle with that, but that's, and to be really blunt about that, we can't investigate individual complaints. That's not what we do. Kate, I don't know whether you want to add to that. No? Okay.
Yeah. I think just to say, the important part of Ian said there is we get half of our inspections are based on what we hear from people who use services and from whistleblowers. And that's a very important part of our work. And sort of making a point I made to Andrea earlier, it relies upon a trust, and not in all services, not in all areas will people trust us, or indeed trust any other part of the system. One of the reasons why, one of the very first questions with the lady from the advocacy organisation, there's a really important part that others can play and help bridge that gap between a regulator and people using services. And I think we are keen to work with everybody that has and is able to touch people using services and their families, so we can bring their voices together earlier, so we can take the right action. We do take regulatory action every day. We'll have taken on average 2 bits of regulatory action every working day, but that's not enough. It needs to become part of not regulatory action, but common practice in organisations to improve and to listen to the voice of people using their services. So that's the work we need to do. That is the challenge that's for us. I think there's a collective challenge working with advocacy organisations, working with people like yourselves, working with others to hear the voice early and to act on it in an organisational sense. So where we know the organisation needs to change, we need to take the right action to drive that change. Next question. Gentleman in the middle.
Hi there, I'm Nathan Jones from the National Care Forum. I'm the Senior Policy Officer, and we are the membership body for not-for-profit care and support organisations. I just wanted to add to some of the comments made earlier about adult social care. Particularly, adult social care needs to be seen as more than just an adjunct to the NHS, a lot more than that. I think in your response you talked about integrated care systems being really important in that, and I would agree. Something that we are seeing sort of in the first few months after their establishment is a very NHS-centric point of view from the leadership of all those systems, which means that the voice of social care is not reaching the top of the systems, is not involved in the strategic design of the systems, and the people that use those services are not getting anywhere near the designs. Everything is very focused on an acute health environment, and that's a massive problem. So I guess one question would be, the CQC, is how will you use your new powers to ensure that that doesn't continue to be the case? And a second thought, in your report you talk about the many challenges services are facing, being linked to historical underinvestment and a lack of sustained recognition and reward for the social care workforce. I guess what more can you do to ensure that staff are supported? How will that impact the way you inspect and look at services? And more importantly, what would your message be to Jeremy Hunt if spending cuts actually do come to fruition?
Kate, do you want to start with some
of
that?
Thank you. Thanks for the question. So I think many of us who have been around for a little while, when we became aware of the establishment of integrated care systems, saw fabulous and not the wider picture. So I am really keen that we can support ICSs to do that broad, to really understand their population, to look at inequalities, to look at access, and we will certainly use everything in our powers to be asking ICSs to demonstrate. So the Secretary of State sets our priorities around what we will look at when we start doing this work, and there are currently 3 areas we've been asked to focus on: leadership, quality and safety, and integration. And for each of those, we will be looking at that across the area. And just to link the 2 points, when we talk about workforce and the challenges of the 300,000 vacancies that Ian mentioned during his presentation, we talk about national investment in workforce, but we want to see local ICSs coming up with bespoke workforce plans within their patch that doesn't just look at the kind of health professionals needed to ensure that people get good quality health and social care. It looks at social care requirements, it looks at the voluntary sector, it looks at their offer for informal carers. So I'm really keen that we look at ICSs considering what needs to happen around workforce in the kind of totality within their place rather than the health. But I absolutely have the same worries that we need to do everything we can to ensure that the focus is broad rather than narrow. A&E, weights, finances of the acute trust, etc. So that's what we'd say around workforce. So we, for a number of years, and again this year, call for a workforce, particularly in social care, that is kind of has the rewards and recognitions for the incredibly tough but invaluable job that they do. And this isn't, again, as we mentioned earlier, this isn't just about hourly rate. This is about terms and conditions. This is about career opportunities. And again, how are local health and social care leaders, how are they jointly going out and pitching people to come into the sector with the potential to be able to describe how you can move between organisations? Andrea was talking earlier about the challenges about being a nurse in a nursing home. And I often think about what it might be like to be a single nurse in a nursing home on my own at night with however many older people with complex needs that I'm looking after. How lonely and daunting that role might be in comparison to being a nurse on a ward with all my colleagues around me. Well, what's the local system offer? How can that nurse feel part of a virtual nursing team where they can get their iPad and pick up a call to a colleague to say, I'm a bit worried about this person, can you give me a bit of advice, etc. So this is absolutely about money and recognition for the work that is done, but we really want to see local leaders coming together to look at recruitment in a way that describes a kind of a career pathway, but also thinks about how they retain staff by how they build a kind of virtual health and social care, leadership team within a place that people feel connected and feel part of that identity.
On the last point about I think sometimes funding for social care in the Treasury is seen as like a sort of almost like a charitable act, and my point is there is a real economic value to having a working age population supported, either to be able to return to work themselves because they've got the right care and the right treatment, or because it releases them from caring for family members. And in a tight economic market, that has never been more important. The other thing that we've said directed to them is, it's to Ian's point, it's better to fund the root cause of the problem than to deal with the sort of proverbial headache of where we are today. And actually, if you don't tackle the long-term root cause, you will just need to put more money into managing short-term fixes. And I think there's a recognition of both those issues are substantially correct. So we'll continue that dialogue with colleagues. Do you want to go next, lady in the middle, and then we'll go to the back.
Thank you. I'm Sally Tabor from ISCAS, the Independent Sector Complaints Adjudication Service. An excellent report, but I think Chris will know what I'm going to say. Too little about the independent sector. What I was pleased to see that you had done work on baby scan units. That came out of complaints that we received via the ISCAS public line with patients ringing, well not patients, but ladies who were early stage of pregnancy ringing saying, I've gone to a scan unit, got a picture done, and somebody has identified that the baby is it's not a right situation that I have got. I think you must include a bit more about the independent sector, and I would like to see the issues that are raised in the independent sector in the report. Our highest level of complaints are consultant-led services, which is not surprising because we're a consultant-led service in the independent sector. But we do have other issues as well around complaints handling, and obviously I'm delighted that Dr. Sean O'Kelly has been appointed because he understands the cosmetic side, and I think there's a lot more to do there. There is huge concerns out there, and particularly you've got number 1 Harley Street interviewing patients to go to Turkey for them to come back and have their corrections made in the NHS. We've just got to stop it. But more on the independent sector, please.
Sure. Sean, if you want to say anything about that.
Yes, well, I would agree certainly with the cosmetic surgery point. There is unfinished business there in many respects. It's a very difficult area, as I'm sure I know you know. How much of that is in the report is a different issue, I suppose, but there's certainly a lot of work to do, and it's always very good to have the inputs from those who are clearly experiencing issues and experiencing problems in that area, and we're certainly that is very welcome. It's very welcome for us to be aware of that. But in terms of the report, I don't know, Chris, if you want to.
I think obviously it needs to be. I think it'll be a feature of our work across systems as well. So I think the independent sector will form an important part of how ICSs operate in the future. So I think as we get into that system work, I can see it being a key feature of that work as well. But your point's well made, and yes, I wasn't surprised, but I recognise the point. Yes, the lady behind. In fact, there's two actually. One, yeah.
Thank you, Chris. I'm Emily Holtzhausen, Director of Policy and Public Affairs at Carers UK. So I just wanted to say that we absolutely wholeheartedly support your call for this to be looked at as well through an economic lens, because the shortfall is being met by disabled people and older people's unmet need, and of course families. Yeah. And around 600 people are giving up work every day because of the shortfall in care. Some of it's choice, actually, as well. Amazing. But do you think we need a bit of a refresh of the evidence and the data sources that see people's journey throughout this? Because a lot of the NHS focuses on the journey of the patient, but doesn't necessarily look at the impact or decisions on families and unpaid carers. There's a clearer lens through social care, but even there, perhaps we need another relook at, I know the data is being worked on, but NHS digital figures are showing that families are getting less year on year and less likely to have assessments. So it would be really good if you could look at that, particularly if you're going back to these integrated care systems, where the person at the centre is the person who is, in effect, knitting up all of that care.
Yeah.
And it could be very valuable for families and people needing care.
Kate, do you want to?
Yeah, but you reminded me of that stat again, Emily, which is astounding. And we were talking yesterday, so I think we've got Health Foundation in the room, and I think adults between 50 and 65, there are 3.5 million not in work, and I think almost half of them as a result of ill health. And again, I think we've got Office for National Statistics in the room, and I think they said that 1 in 5 people are on waiting lists. So it's how we describe this gridlock system. There are people waiting for assessments, waiting for treatment, and there is an economic consequence as well as a very human consequence to that. In our report today, so we did a piece of work where we spoke with 4,000 people aged over 65 around the country who had an interface with health and social care over the last 6 months. And we found that 2 in 5 of those people who were waiting for a health or social care assessment described a deterioration, and they described the point that they were being interviewed, that they were needing more support than they were at the point that the assessment was first requested, which is obvious, but I think there's no harm in just reminding people of the human as well as the economic cost of waiting. And again, just out of interest, when we were talking to those people about what would make a difference, very simply they were saying, tell me where I am on this waiting list. Let me know when I will be seen. But also, can you just tell me I've not been forgotten, please? Can you? Is there just some way of saying we will get you, and it will broadly take this amount of time? So I know it's obvious to say simple, and I know it's very hard to be able to describe when someone, as a previous director of social services who had a waiting list, you're always prioritising risk, etc. So it's not as simple as it sounds. But yeah, that clear message is coming back from people around deterioration while they're waiting to get the assessment they desperately need, and a plea for just tell me that when I'm going to get seen, and that you haven't forgotten that I'm on the waiting list as well.
I think the lady behind her, and then there's a lady in white.
Oh, thank you very much. So, Ruth Isden, the Head of Health and Social Care at the charity Age UK. So I had a point of agreement, an observation and a question. So I think I absolutely agree with you, Ian, that we need to be really clear about what's going on here, and we need to call a spade a spade. We know, and it is to confer very correctly from your report, that people are suffering serious and avoidable harm, and in some cases they're losing their lives because of the gridlock in the system that you describe. And I think we need to just be very open and honest about that's the position we find ourselves in, and that is no comment on the staff or leaders across the system who are doing the best that they can. I think my second point of observation, though, is it's very tempting at times like these to look upwards to government. And of course, because there are things that we all know that we want to see from government in terms of funding, investment, long-term planning, policy strategy. But I think the reality is, given where we are today, that not much is going to be forthcoming for the time being. So we actually need to look outwards to each other. And, to coin a phrase, I think we're on our own now for the time being. So it is up to us, the people in this room, at national and local level, to come together and do what we can do. And I think you're very right about that in the context of where we are. So with that in mind, given your bird's eye analysis of the system as it stands today, what are the 2 or 3 things that you're most worried about over the next 6 months? And what would you like to see the system, us collectively, in the broader sense, doing about that?
Do you want to start, or do you want to?
I'm just trying to think of only 2 or 3 things. Do you want to start? Well, I think.
So there's on the practical. So we've written 2 documents this year. One called Patient First, one called People First. They're really guides for people working at the front line of the first one, health, the second one, health and care, around how to manage during winter. And I think there's a really important part about, so we've written People First, which is the second of these guys, and actually we'd probably need to do something again in the next week or so to make a really simple look. This is how we want you to engage across health and care boundaries as we approach winter. So people are making difficult choices, balancing relative risk. And I think probably what they need from us is a sense of what's the guide to help them manage relative risk at a difficult time. So we've been working, we're blessed really, we've got some very, very, very good people who work in frontline clinical roles and in frontline social care roles that have been working with us on these documents. And I think my thinking is we started off with quite a sort of, it's an all saying all dancing document. We're probably going to get to like a one-pager, which is just these are the things that are really important to do as we approach winter. And that guide is for people so that when they're making decisions that are difficult decisions, you know, on a Friday night at 11:30 in A&E, or on a Sunday morning when they're trying to place somebody as an emergency into potentially into social care, what do they do? So I think we need to be practical about that and offer as much guidance to colleagues who are working in the front line. And I think the other, and Kate's already mentioned this, so probably still a bit of Kate's thunder, how do we help local authorities and ICSs think collectively about what they need to do together? How do we provide the right information? How do we provide the right support for where they are today? What's their starting position? And how can they improve from where they are over the next 6 to 12 months? And I think there's something really tangible. So one's very practical for the next 2 or 3 months. The next is, how do we get into a situation where, as we approach the next spring and, God forbid, the next winter, we've got ahead of the game in terms of where we need to invest in social care, where individual areas need to think about their provision across services. So I think a catalyst for the second and a practical guide for the first would be my two.
I think my one, I think probably on reflection, is that people lose their humanity. I think, you know, if you've got 300,000 vacancies, if you come into work every night and it's chaos on legs, you are going to get to a point where you can become quite tribal, and you can be quite inward looking, and we've seen examples of that in the last week in terms of some of the things that were reported in the Health Service Journal around ambulance crews versus ED teams. How much of that was really true is for debate, but I do think that, you know, as leaders, we've got to kind of double down on that, because, you know, when we look at, you know, examples of maternity, where that's about people losing their humanity, between why wouldn't doctors, nurses talk sensibly and caringly to women having babies? Why isn't that happening? Well, it's happening because people are under a lot of pressure, and when they're under pressure, they react in a particular way, and people pull apart from each other rather than come together. And I think, as you were essentially alluding, you know, there isn't a big bag of money somewhere to fix all of the problems, and even if there was, there probably isn't the people to hire to fix the problems anyway. So these are not simple problems, but I think what we do have is the people that are already in the system, and can those people work together collaboratively more effectively? And in the short term, that is about simple humanity. And the sort of the counter to that is, if that doesn't happen, people start to relationships break down, and it's an awfully long way back from a relationship breaking down. So that humanity point probably would be my thing. Kate. And
if I could just jump on this. So we know that informal carers need a really, really, really small amount of support to keep going in the invaluable work that they do. And we know that through the pandemic, access to kind of respite, luncheon clubs, work opportunities almost stopped and haven't fully recovered in the way that they were. We were talking to an integrated care system in the last couple of weeks where I met an acute chief exec who decided to move a chunk of their money out of the hospital and gave it to the voluntary sector. And they weren't hugely prescriptive about what the voluntary sector did. They just said, can you broadly deliver these sorts of outcomes? And that would be what I hope we can do going forward. But if you had a small amount of money between now and winter in your local system, how can you direct it to give a little injection, a little bit of prevention, a little bit of respite for informal carers that can just keep them going? Because a small amount goes a very, very, very long way. And I just hope there's more we can do to describe it doesn't happen very often, but the parts of the country where people can think outside of the silo of their organisation to actually, you know, £5 million is delivering me this, but actually if I moved it to a different part of the system, how much more value would £5 million get in terms of keeping a larger number of people well and not crashing into hospital when they don't need to?
Can I add one thing as well? Because there's a lot of things we worry about. One thing in particular I worry about is our ability as a sector to understand and identify the hidden harm that might be out there, that we know probably is out there. How do we detect that? How do we respond to it? Are systems under pressure? Are organisations under immense pressure? do they have the ability or the appetite to do that? They really need to do it. We need to find that harm before it becomes irreversible. The other thing I really worry about is the experience of the new learners we have in our organisations, the people that are entering the professions, that they don't see this, the way that the health services operate at the moment, the gridlock we see as normal, that they don't normalise that. And that is, you know, I remember when I became a junior doctor 40 years ago nearly, it's a really impressionable time. You are looking at learning how to be a professional in the system you've joined. And it's very important that our learners are helped to understand that this is not normal, and the way that we are at the moment is extreme, and we need to support them. Otherwise, the future, we're losing a bit of the future as well. So that's just two of the things I worry about. I could go on, but I won't.
Tell me, we've got lots of words between us. Lady over there and this gentleman there. Lady first. If you do lady first, then sorry, just to. Yeah, you're next.
Hi, I'm Charlotte Gill and I'm from Voiceability. We're a rights and voice organisation, and one of the services we provide is also advocacy services. I really welcome the more forthright style of communications. I think that is pretty important because of the situation we're in. Particularly if I wanted to just pick up on the second, I would say, low light in terms of the care and treatment of people with learning disabilities and autistic people. And I wanted to reflect on the Building the Right Support Action Plan. And I wondered what the CQC whether the kind of panel could reflect on the CQC's role in really supporting to drive that forward, in particular in these political times, conscious that the CQC is not a political organisation, it doesn't have a political role, but inevitably we all operate in that environment. And I think there is a potential risk of a real lack of ministerial drive, accountability, prioritisation of the action plan, which is really crucial for those circa 2,000 people who continue to remain in mental health, inpatient settings for a long time when they really shouldn't be there. So I wondered what the CQC could reflect on its role and whether that needs to shift given the current climate we're in and how that will work.
Okay,
so some of our work is around influencing and providing information to get action to happen. Other parts of our work are taking action ourselves. So as you know, we published out a site. We did an update report this year that said there's been a load of financial investment. Everyone is on the same page. Everyone believes that less people should be treated in hospital a long way away from their home. And everyone supports that there should be a comprehensive crisis service around the country to keep people well in their usual place of residence when they need that. However, our progress report found that with all that best will and that investment, has that translated to improved outcomes for that group of people? No, it hasn't. So we will continue to call that out. But we're also doing some concrete things as well. So you might be aware of a policy we developed a little while ago that's been refreshed called Right Support, Right Care, Right Culture, which is our, based on NICE guidance, it's our commitment to only register services for this group of people that are in keeping with best practice, so small, community-based, enabling people to have meaningful lives. We've had that policy in place for a number of years. We've gone to court to ensure that providers are only coming online, setting up services which meets that requirement. And we will continue to do so. And we are very regularly, so again, everyone supports this policy. Everyone's like, this is a great policy. We are regularly having conversations with commissioners that say, great policy, but actually I really need to build this extra wing on in order to ensure. So this is a daily commitment from us to ensure that there are the right services out there, and we will continue to do that. And then just one other thing to add is where we've been going to those sorts of services where we know generally people aren't getting the best outcomes because of the environment, we are taking action and we have closed some of those services, and we will continue to do that as well. So. It's kind of stopping new services coming into the market that aren't the right model. This supporting providers to exit the market if they can't provide the quality of care that people expect. And then there's kind of a bundle of work in the middle around things like we've set up a supported living coalition with people who use services and families around what should good supported living look like as well. So there's kind of a number of prongs. But we will continue to engage with that ministerial group and do our influencing. But there are also very concrete regulatory actions action that we can do as well to drive this forward, because this is something, you know, I'm absolutely passionate about, and it is just unacceptable, the lack of progress that's been made in this area.
Good morning. I'm Philip Batty. I'm the President of the Independent Doctors Federation. Ian, first of all, I'd like to really thank you for calling out the health inequalities based on ethnic minorities. I'd like to ask, maybe Sean, if you don't mind, how are you dealing with the challenges of ethnic minority-led primary care services, particularly, that, as you highlight, are facing great challenges with the most demanding and socially deprived populations with the greatest healthcare needs? How are you tackling that, and how are you engaging with those GPs? So that's one question. The second one is, I'd just like to think pie in the sky. Realistically, Ian, possibly to you, in 12 months' time, when you're presenting this state of care, what would you have liked to have changed, and what would you like to be sort of saying in a year's time that's changed, if that makes sense? Thank you.
Sean, I think obviously there's the work we did earlier in the year, but do you want to talk to that?
Yeah, of course, yeah. Through the Director of Primary Medical Services for the CQC, Dr. Manny Hussain, he's been leading work where they've been getting more data, more information around how those practices are functioning and what support they need. And working, of course, I think some of the answer for the problem is working with primary care networks and the new integrated care neighbourhood teams to support those practices. In my previous role as NHS Medical Director in the East of England, we had a lot of areas of deprivation in Essex, in particular in parts of rural coastal East of England, where single-handed practitioners were working very hard to try and make an impact. But there is an anomaly, isn't there, Chris, in some of the way that because of the way that funding is quite complicated in primary care, as I'm sure you recognise, some of those practices are actually at a disadvantage in terms of the support and funding. So we are working to understand that, working to highlight that and to emphasise that, and to work with system partners to address as much of that as we can. Chris, I don't know if there was anything else I missed out.
What was really interesting about the report we published earlier in the year was I don't think we knew the extent of the discrepancy that you get into in terms of funding, because people who are looking after cohorts of people in high areas of deprivation don't get access to 50 plus healthcare checks. So they just don't get access to some of the funding that other areas do. And I think the challenge lies in, so I've called this out as a thing, and I've sort of linked this very much to areas of deprivation. I think there's an open conversation with both national leaders and ICSs around, well, how do we change that funding mechanism? Because it's counterintuitive and counterproductive, frankly, to create it in a way that means that GPs that are working in some of the most deprived areas are likely to get less funding. I think we know the GP funding model will probably change anyway, but paying people for tasks when actually you want to keep people well, there is a different way into this. Now, I hope the combination of the way in which ICS will operate, some of our evidence playing into that, and some conversations we have with NHS England, we think hopefully what might change the dynamic of how that operates.
And my sort of very quick response around what we'd like to see change, I'd like to be in a position to say that ICSs are working, because I think what we're seeing is ICS is starting to form. We've seen some good ones already. We've seen some ones that are still a relative fledgling stage. I'd like to see everyone accelerated up to a point where I can stand on the stage and confidently say ICSs have got a good view of their place, and they understand their population, and they're making the best of what they've got, and the fact that the joining up is the sum being greater than the sum of its parts. So, well, the whole being greater than the sum of its parts, I should say. Excuse me.
Given a fast wind-up mechanism, there's a couple. Any final questions from colleagues? We'll do the last two, and then I do the same with the media brief, and the media team get annoyed with me as well. So do those last two questions if that's okay.
Thank you. So my name's Gemma Quayle. I'm from the Office for National Statistics. So I've got one broad question and one specific question, if that's all right. So you mentioned the importance of better data to help with coordination and to address inequalities. So what I'd like to know is, how are the CQC improving both data collection methods and improving the amount of detail of data collected? So for example, we would be interested on learning more about the characteristics of care home residents. And then my more specific question is in relation to the gridlock of services that you mentioned so well, is whether we have any specific data that the CQC collects on the number of hospital patients that are discharged into care homes and the number and proportion that are waiting to be discharged to care homes at any specific time.
I've got a bit on the set. Do you want me to go? Do you want me to go? Yeah, let me look at this. So let me just do the second one first, because I can, even though it's more detail, I can remember it. We look at information we collect upon discharge, and you can see for different areas of the country, there's always been a portion of delayed discharge because of general problems, usually with medicines, usually with community care and support in the community, and that's stayed roughly static nationally at about 20%. What we've seen is a rise in the amount of delayed discharge due to lack of community and adult social care support. So that's the delta. So to give you an example, in the South Coast there's a hospital where in the surrounding area, immediate surrounding area, it's lost about 40-45% of its domiciliary care in the last 6-7 months. That has had a direct impact on the people who need that support to be able to leave hospital. So we're trying to track those things. Just to play back to the other points we made earlier, adult social care is much more than just this feature, but nevertheless this feature is important because it has a direct impact on people's ability to live normal lives. Because people, as we know, once they're medically fit to be discharged, can often degenerate if they don't get into the environment that's right for them. So we do gather that information, and part of the role of our working across systems is to look at the relationship between hospital 4-hour wait, ambulance wait times, and the registrations of domiciliary care in an area. So you can see a correlation between the delay and the number of delays in a hospital environment and the proportion of adult social care beds and domiciliary care agency support. I have now completely forgotten the first part of the question.
So the only thing I'd add, it probably is a bit specific, we probably do need to take it offline, but our whole new strategy is about how we can ensure that the data we have on providers and on local authorities and systems when we have it is up to date and is available for the public. So our ambition is around transparency, up to date information, but also providing information in a way that enables providers to benchmark and compare and contrast with other providers. So we are on that, that's the route we're heading on, and our new single assessment framework and the new tech and digital functionality we're building in the organisation is to deliver that vision of having more up-to-date data, more available to the public in more live time, but also that kind of transparency and that ability for providers to benchmark. But we might want to pick a conversation up with you offline if that's okay.
Take the last question of the gentleman in the middle. Just to say, we are evangelists of the Health Index, your guide to relative inequalities in the area as well.
Hello, I'm Jabir Butt from the Race Equality Foundation. Ian, to firstly thank you for once again raising the issue about the maternity care for Black and Asian women. Some of you recall I've been whining for some time about the lack of continuity from one report to the next, and the fact that this is the third year running you've raised it is actually a welcome point, because it needs to be addressed. My worry, however, is that in the summer, NHS England stepped back from a key development that they'd said they were going to use to address that inequality. That was the issue about continuity of care. That announcement was made in the summer that it was no longer going to be a requirement of midwifery services, and unfortunately it seems to have gone without much comment from anyone that actually this is a backward step rather than a forward step. And I really do think that this is an area where the CQC really has to exercise its muscle and say that what we'd shown in the past was a problem, and the fact that last year we reported it wasn't being done very well shouldn't have led to us now saying we're not going to do it at all.
just to say, I'm not sure what's coming, but just to say, we're publishing, as you probably know, we're doing a round of inspections in maternity service at the moment in the interim report for that. So what we want to try and do is have some evidence. I think your point's well made. What we want to do is try to back up that point with some evidence around the implications of it not being in place. But I absolutely take your point. I think we'd like to get some evidence from the inspections to help make that point more forcefully. But we will publish some interim findings around those inspections as we go through, probably into the early part of next year.
I think that makes sense.
Yeah. Okay, well, thank you for sitting in what are not necessarily very comfortable seats for an hour to hear us talk about State of Care this year. And thank you, as Ian said at the very start, a lot of what State of Care relies upon is the conversations and the engagement we have with you as a wider community. I hope you found this useful. I hope you found our messages useful. As I said at the start, State of Care isn't a day. It's a conversation about health and care that goes throughout the year. So I hope very much to engage with you and colleagues in the coming year to talk about some of the things that we've raised today. As a reward for staying for us for the length of time, there is more coffee and other things downstairs in the room that we were in at the very start. For those of you who can stay for a bit longer. But thank you very much for today.
But before coffee, please can you fill out the forms on your seats, which are feedback forms.
Very good.
And Aisha will allow you to go through the door to the
Indeed,
coffee once
yes.
you can hand that in. So
Well
thank
done.
you very much for doing that.